Good afternoon, ladies and gentlemen, audience and delegate speakers. First of all, thank you for Bristol Mayor for the invitation to let me moderate the session. Um, a very interesting session for the new update issue on the immunological uh, oncology drug today for GI cancer treatment. May I introduce myself first of all? My name is Dr. Sirikan Limpakan Yamada, who works in the northern Thailand region in the Tertiary Care Hospital Center of the Chiang Mai University. My expertise is a GI oncologist surgeon, and actually, I involved of some research on the chemo-resistant therapy for the gastric cancer, and especially I do treatment for the gastric cancer most of all. For the esophageal cancer in northern Thailand, we have the less number comparing to the incidence in the southern part of Thailand. So may I show the next slide, please? Okay. Uh, this is actually in my suit and my gown that I have to wear the green suit for my surgery. And the problem related to multidisciplinary issue. We may have the advanced drugs component for the treatment of the esophageal and gastric cancer. Globalized treatment and Asian treatment may have some difference for the chemotherapy regimens, radiotherapy, and immuno-oncological treatment. For the advanced stage, esophageal and gastric cancer, immuno-oncological treatment and or immune checkpoint inhibitor, we have just had some new knowledge in the field since after year 2018, and biomarker expression still have some reluctant results for the decision. Treatment related adverse events still be unknown because most of our patients has no treatment for the targeted therapy yet. Residual tumor after neoadjuvant chemotherapy, we have some problems still. And we may summary after Dr. Lam, who is our delegate speaker today, talk about it. Chemotherapy resistance may cause poorer outcome of overall survival in terms of partial responders with the residual tumor after neoadjuvant chemotherapy, complete resection. Also, we complete resection, but we still have the problem for the treatment after that, mostly because of the patient have no fitness enough after surgery, especially after neoadjuvant chemotherapy. Therefore, this is a point that we still have some problem related to the treatment to keep the overall survival of the patient better. The positive lymphatic metastasis also cause a poorer survival in more than the half of complete resection patients. So we found the recurrence with the metastasis that cause poorer survival. For the incidence of the global incidence of the esophageal cancer and the metastasis site also have some difference among the population. So this is a problem that we found the responsiveness of the chemotherapy and treatment may have some difference among the region, and 90% of patients who diagnosed at the end stage almost have the fatal condition after that. And what I said before, after the neoadjuvant chemotherapy, even for the GE junction tumor, after we succeed to cut it, but after that, we can't have the further treatment that may cause the patient loss after the surgery. And when we want to add the treatment, the patient has no fitness enough. Therefore, we think that some kind of targeted treatment may be useful in this population. And also the risk of recurrence after the neoadjuvant chemotherapy and resection also very high. And in 1 year, we also have the recurrence that also combined with the metastasis. More than half of the patients that is still in the reluctant condition if we should add the other treatment for the patient or not. And if you can see the survival after 5 years, 3 years, with or without complete response, we may see the survival is less, number more than half, if it collaborate with the residual tumor. And almost the patient has less than 6 months survival. And also gastric or esophageal cancer may lead the cause of the GI cancer in the world. Even it's a number 6, 5th or 6th, but for us in GI world is the cause of leading cause of death for the cancer, especially gastric cancer. And in our center, we try to accumulate the case, and we progress the treatment or advanced treatment, even nutrition or other immunological treatment that we start from year 2016 or 17. However, the number of cases is still not reach the summary result. I try to collect the data of the CMU study, and we can increase only maximum to 37% from 8.6% for the 5-year survival. And we study about the drug resistance during past 5 years and report that we found the DNA repair has some problem of the gastric cancer patient. Also, the cytokine that cause the poor chemotherapeutic response for the gastric cancer. And for myself, I especially treat the gastric cancer, and we hope that the host response to some therapeutic agent may increase the survival rate. The current treatment of our center are actually only chemotherapy, and including adjuvant and neoadjuvant therapy. And mostly we use the cytotoxic drug regimen in the combination with the 5-FU. And we still have the poor prognosis in the advanced stage. This is some of my slides that show our result of the treatment in year 2019 after we collect the case. And we have, I show only a part of the story that one part is for the treatment of resection in the stage 4, that we still gain the survival at the median time about 13 months for the 4. And overall survival in stage 4 still be better after we use the neoadjuvant chemotherapy and use conversion surgery for R0 resection, that gain survival benefit from 4 regimen to 17 months for the median survival. And for subgroup analysis for the success case succeeded to treat for the conversion surgery, we can keep the patient at the median survival of 20.53 months. And for the cisplatin, almost they still have the good response, but most of population drop from the complete protocol due to toxicity and some of the intolerable conditions. So for the subgroup analysis of the conversion surgical rate at the 43% that we can achieve conversion surgery. Both that success neoadjuvant chemotherapy during past 3 years, success rate about 30.52%. And its well response case can have a prolonged survival. Both the success rate per total conversion rate is 70.73% that achieve to perform definite surgery per conversion surgery without complication and prolonged survival. But I still have not yet satisfied this result of our long-term collecting data. Even the group that have the intolerable condition from the chemotherapy. In summary of Thai advanced gastric cancer, we succeeded to do conversion surgery without problem in most of the case that can gain response rate from the chemotherapy. But out of 50% or more than 50% of stage 4, we cannot achieve the prolonged survival of the case, and the target of responsiveness treatment on the second or third line still not reach our satisfactory. May I shift to our talk, our delegate speaker today, who involved with the primary investigator of many interesting trials in the globalization. Today's topic, Dr. Lam, who graduated in year 2005 for the master degree in Hong Kong, and he got the fellowship in UK around year 2008. Also, he involved with many trials that now is going on with the targeted therapy, especially on the immuno-oncology field for the upper GI cancer. May I ask Professor Kaon Lam to give our talk today. Thank you.
Thank you, Chairperson, for the nice introduction. And it's my tremendous pleasure to join the annual meeting of the Thai Association for the Study of Liver Disease. I'm Dr. K.O. Lam, specialist in clinical oncology and currently associate professor in the Department of Clinical Oncology, Lee Ka-shing Faculty of Medicine and the University of Hong Kong. My topic today is evolving treatment landscapes of IO, immuno-oncology in upper GI cancers. These are my conflict of interest. And here's the disclaimer. So to outline the evolving landscapes in upper GI cancer, we'll go through the esophageal cancer and gastric cancer. I will walk you through the evolution of treatment landscape. So before we go into specific disease, let's have a quick revision of the immunotherapy for gastric and esophageal GEJ cancer. As we all know, immunotherapy is an emerging treatment modality for all cancer. And translational studies and molecular classification suggest gastric and esophageal cancers are candidate malignancies for immune checkpoint inhibitors because there is overexpression of PD-L1, a biomarker to predict treatment efficacy of immune checkpoint inhibitor in gastric and esophageal cancer, and suggests that immune checkpoint inhibitor may be an effective therapy. Of course, we have different goals of therapy, and certainly the goals of immunotherapy is quite different from chemotherapy. With immunotherapy, we have to eliminate immunological tolerance to the tumor so that our immune cells can attack the cancer cells again effectively. And we have to induce tumor immunity with specialized cytotoxic cells based on antigen expression on the tumor surface. So to bring up synergism between conventional chemotherapy and immunotherapy. We all know that the immune system is capable of eliminating tumor cells. through multiple steps of tumor recognition, presentation, and finally killing of cancer cells. But unfortunately, there is a constant evolving immune escape mechanism from the very smart cancer cells. For example, ineffective presentation of tumor antigen, recruitment of immunosuppressive cells, and release of immunosuppressive factors, as well as T-cell checkpoint dysregulation. But we are very smart too. Scientists have developed a few ways of suppressing or reversing this immune escape mechanism through the use of vaccine, antigen processing, and immune priming. Of course, one of the breakthroughs that we have in the past decade is the recognitions of the immune checkpoint pathway and the use of immune checkpoint inhibitor, which will be our main topic today. Basically, what we are referring to immunotherapy today is just part of the immunotherapy, and basically it's only the immune checkpoint inhibitor. The two very well recognized targets are the PD-1 or PD-L1 and CTLA-4. And with anti-CTLA-4, it induces de novo anti-tumor T-cell responses. It enables adaptation to evolving tumor. So we have making the immune system smarter to tackle the evolving cancer cells. And also there's promotion of emergency of memory T cells so that this anti-tumor immunity can be durable. With the anti-PD-1 or anti-PD-L1, we restore anti-tumor T cell function and reverse the T cell exhaustions that lead to immune tolerance. We also increase the cytokine production and in a way that eliminating the cancer cells effectively. So basically anti-PD-1, anti-PD-L1, or anti-CTLA-4. But back to the upper GI cancers, the situation is very muddy, very confusing, and a lot of ongoing studies are being done. But luckily, the situation is becoming clearer and clearer, with more and more landmark studies which are proven positive with clinically and statistically significant positive results. If you look at this, if you look at all these different parts of the esophageal, gastroesophageal junction, and the gastric body, you know there are different studies. Basically, with the two main flagship immune checkpoint inhibitor. Checkmate, as we all know, is using nivolumab with or without ipilimumab. Keynote, as we all know, is using pembrolizumab. So first, about esophageal cancer, you know, it's the fifth commonest cancer in the world and the sixth leading cause of cancer-related death in both sexes worldwide. So it's basically an important healthcare burden. And worldwide, squamous esophageal cancer is more common than adenocarcinoma. However, regional distribution vary greatly. Squamous cell carcinoma is located mainly in low resources countries, such as Southeast Asia, Central Asia, and Latin America, while adenocarcinoma is most common in Northern and Western Europe, North America, and Oceania. So when you are, so one tip to guide you through the evolving data in the IO for the upper GI cancer, you have to make sure that the study population is relevant to your own population. For instance, in Thailand, we will be focusing more in the study that recruit mostly Asian patients. So in the first, we go through the adjuvant setting. Everyone must learn about this Checkmate 577 study, in which our center has also contributed patients to this study. Basically, in randomized patients who have undergone neoadjuvant chemoradiotherapy and a complete resection of the tumor, and randomize them into either observation, which is the standard of care at that moment, or to 1 year of lifilumab. One thing to remind you about the eligibility is that those patients who have complete response are not included in this study. Only those patients with incomplete response but complete resection of the tumor will be included. The primary endpoint will be disease-free survival. And the result was presented with a practice-changing effect. Let's look at the baseline characteristic. Most of the patients, 2/3 of the patients have advanced disease, which is stage 3 disease, and most of the patients have esophageal carcinoma. Only a minority of patients, which is 1/3 of patients, have squamous cell carcinoma. So that will dampen the relevance of this study to our own locality because of the patient population and proportion. Nevertheless, the disease-free survival is significantly improved. With the use of 1 year of adjuvant nivolumab, the disease-free survival at median is double than that of the placebo, and the two curves separate widely with a hazard ratio of 0.69. And if you look at the subgroup, it seems that all subgroups will benefit from the use of adjuvant nivolumab. Initially, the study was presented with TPS, the tumor positivity score, which only showed the PD-L1 positivity on the tumor cells. But with the updated data, it also showed the CPS, which is the combined positivity score, which also take into account the positivity of PD-L1 on immune cells. And it shows that the PD-L1 CPS should have some predictive value. With higher the CPS, the better the hazard ratio and more significant the treatment effect. And in fact, it seems that those patients who are more advanced with lymph node status should have a more significant hazard ratio and treatment effect with adjuvant nivolumab. In the updated presentation, it also showed that the distant metastasis-free survival is significantly prolonged from around 18 months to 28 months. So that is a very important point, because you know esophageal cancer are aggressive when they recur. Usually they have distant metastasis, and that will be a death sentence for our patient. So prolonging distant metastasis-free survival is an important outcome for any adjuvant treatment in esophageal cancer. Progression-free survival 2, PFS2, is also prolonged. It actually measures from the time of randomization to the time of progression from the first systemic therapy during the recurrent status. So it showed that at least nivolumab, the effect will be persistent, will be preserved even after the first-line palliative treatment. TRAE with potential immunological etiology, what we worry about will be pulmonary, because these patients, by definition, should have received thoracic chemoradiotherapy in the neoadjuvant setting. So we always worry about any potential effect of giving rise to more pulmonary immunological IRAE, the adverse event. But luckily, the adverse event in the pulmonary category is very low. So in summary, adjuvant nivolumab demonstrated clinically significant and meaningful efficacy in patients with resected esophageal cancer or GEJ cancer. The hazard ratio is 0.69, which means a 31% reduction in the risks of recurrence or death and a doubling in median disease-free survival. And the treatment-related adverse event with potential immunological etiology resolved for most patients, and there's low new arising toxicity profile. So these studies provide further support for adjuvant nivolumab as a new standard of care for patients with resected EC or GEJC. So the situation in the adjuvant setting is easier for those who are treated in curative manner with neoadjuvant chemoradiotherapy and complete resection. Nivolumab should be considered a standard of care. In the palliative setting, esophageal cancer, we focus on the first-line setting because what we know for years is that with the different checkmate and KEYLOGE studies, second-line or third-line immune checkpoint inhibitor is effective and have been an approved indication. So we look at the first landmark phase 3 randomized control trial in the first-line setting for esophageal cancer, the KEYLOGE 590. If randomized patients who are treatment naive with either squamous cell carcinoma or adenocarcinoma to pembrolizumab with chemotherapy, the standard cisplatin 5-FU, or chemotherapy alone. The primary endpoint is overall survival and PFS. And if you look at the baseline characteristic, because whenever we go through any landmark study, we should ask ourselves, is this trial relevant to our patient? Is our local population being represented in this landmark study? So patients from the Asia region will account for around half of the patient. So basically, it's a study that we can very much rely on. And the esophageal squamous cell carcinoma represent around 3/4 of the patient. So making this result even more relevant because in our locality, esophageal squamous cell carcinoma is the predominant subgroup. In the efficacy result, it showed that if we stratify patients by their PD-L1 scoring, combined positivity score, the CPS larger than or equal to 10, they will have a maximal benefit, with the median survival improved from 9.8 months to 12.4 months in all patients. And in those patients with higher CPS, this effect is even more enhanced, with the survival improved from 9.4 months with chemotherapy alone to 13.5 months with the addition of pembrolizumab. So that is a very significant improvement. We haven't been heard of very often in the past decade for esophageal cancer. So finally, we are seeing light at the tunnel. And with the efficacy results in esophageal cancer and PD-L1 CPS more than or equal to 10, the efficacy is even more enhanced. The curve is even more widely separated, with a 5-month separation in the median overall survival. So that is very relevant to us if we are considering immunotherapy and if we are treating esophageal squamous cell carcinoma in our locality, then histology should favor the use of pembrolizumab. And if the CPS score is even higher, then it will be a better tool to counsel the patient for the more confirmed benefit with the addition of immunotherapy. The other thing is the more recently published is the CheckMate 6-4X study, which is actually the first study to show the benefit of combining the two immune checkpoint inhibitor, nivolumab plus ipilimumab, in a chemotherapy-naive manner that improves treatment outcomes in esophageal cancer. And this study is even more relevant to us in the Asia, for Thailand people, for Hong Kong people, for Chinese patients, because it randomized only esophageal squamous cell carcinoma. So the CheckMate 6-4X study, the design is like that. So it's a 3-arm study, a bit complicated, but the first arm is immunotherapy alone. The second arm is immunotherapy alone, chemotherapy free. The other 2 arms are chemotherapy with or without immunotherapy, which is the nivolumab. The primary endpoint is overall survival, and progression-free survival. As we know that all of the patients are ESCC, and those patients mostly are from Asian, 70% are from Asian. So you look at the overall survival for the primary endpoint in tumor cell PD-L1, which is the TPS, higher than or equal to 1%. There's significant improvement in overall survival. It's a 6-month difference in median overall survival. And with regard to all randomized patients, regardless of the PD-L1 expression, the survival difference will be 3 months. Both are clinically significant and statistically significant. And again, if we look at the forest plot to look at the subgroup, we try to identify patients that will have potentially have less benefit from this combination will be female, but I guess it's more about statistical because this group is underrepresented in this study. The other will be the tumor cell PD-L1 expression. In this way, it's just TPS. Those patients with low PD-L1 expression will have minimal benefit in terms of survival with the addition of immune checkpoint inhibitor. And there's a trend showing that higher the PD-L1 expression, the more significant the benefit will be. So that is the progression-free survival, nivolumab with chemotherapy versus chemotherapy alone. Two curves are separated widely, representing clinical and statistically significant benefit. One thing about this combination is the response and duration of response. The response can be as high as 53% in the combination arm versus just 20% in the chemotherapy arm. I doubt this chemotherapy overall response rate will be a bit low, but anyway, the combination arm shows a very reasonable objective response rate. And the duration of response is up to 8 months in median. And some of the patients, because in all immunotherapy study, we are looking not just at the median of the survival curve, but looking at the tail of the survival curve that potentially can promise a durable response and a near cure situation, which is possible. Another thing we will be very interested in this study is the use of chemotherapy-free regimen, because in esophageal squamous cell carcinoma patients, they're usually old, they're smoker, drinker, have a lot of comorbidities. If we can get rid of chemotherapy and produce an equally impressive treatment outcome, then that will be very much sought after. So with the nivolumab and ipilimumab combination, the median overall survival favor the use of the combination arm. Although one thing that we have to look at is the crossing over of these two curves, which is very common in all other cancer types with immunotherapy alone therapy. In the long run, the immunotherapy may be the winner, but in the short run, we have to be very careful in selecting patients because they run the risk of rapid deterioration on non-chemotherapy arm. So again, most population subgroup will favor the use of combination arm, and especially there is a trend towards increased PD-L1 expression and a more favorable response. That is the same with progression-free survival, which is less impressive. But again, most of the other immunotherapy study also show a modest improvement in PFS, but a more remarkable improvement in overall survival for various reasons. And the duration of response let's look at this nivolumab plus ipilimumab in this PD-L1 high expression subgroup. You can see that the objective response can be as high as 35%. And the complete response rate is very much comparable to the immunotherapy chemotherapy combination arm, which was 70% in chemotherapy plus nivolumab, but 18% in this nivolumab plus ipilimumab. So in those who respond, they respond very remarkably. Treatment-related adverse event, of course, we are worrying about the combination of levo plus ipilimumab will cause more toxicity, but basically those with addition of chemo actually have numerically more side effects. Even in the immune-related adverse event, the nivolumab plus ipilimumab actually show only increase in the endocrine-related adverse event and the skin-related adverse event, which is not a new finding. And other side effects like the gastrointestinal, hepatic, and pulmonary are similar with different arms. So that finished our walkthrough about the esophageal cancer, both in the adjuvant setting, curative setting, and palliative setting. Immunotherapy, either monotherapy or doublet, will represent a new standard of care. And about gastric cancer, which is even more common, the 5th commonest cancer in the world, causing the 4th commonest cause of cancer-related death. The role of chemotherapy has been traditionally regarded as standard, with survival of around 3 months for best supportive care alone, 6 to 9 months for combination chemotherapy. But that's something historical. We still need chemotherapy, but we don't use that alone. And these are the summary of 3 randomized controlled trials that use anti-PD-1 plus chemotherapy. Basically, the KEYLOGE 062 study, which we will regard it as negative in the overall population. CheckMate 649, which is practice changing and meet all its study endpoints. Attraction 4, I will say, is a half successful study because the PFS is improved, but the OS is not significantly improved. However, that is most relevant in our population because Attraction 4 study mainly recruit Asian patients. So here is the result. So you can see that KEYLOGE 062 actually have very more dramatic results in depending on the CPS score. And the CheckMate 649, we will go into details later. And Attraction 4 meet its primary endpoint of median progression-free survival improvement, but not the overall survival improvement. So that is the CheckMate 649 study. Basically, it's a 3-arm study that our center has also participated. Unfortunately, unlike the esophageal cancer 648 study, the chemotherapy-free regimen is obsoleted in this study, and the levo plus ipilimumab arm was terminated early due to futility. So what remains is the chemotherapy with or without nivolumab. So again, if you look at this study, however, the Asian population is underrepresented, which only represent 1/4 of our patients. And most of the patients have cancer in the proper stomach. So the overall survival is significantly improved from 11.1 months to 14.4 months with a hazard ratio of 0.71. And the overall survival in different subgroups, including the CPS more than or equal to 1, also shows statistically significant improvement, but a less enhanced hazard ratio in all randomized patients. So if you walk through this CPS progression, you can see that by looking at the hazard ratio, those patients with higher CPS, the hazard ratio is 0.68. For those with higher than or equal to 1, the hazard ratio is 0.74. In unselected patient, which means all randomized patient, the hazard ratio is 0.77. So the pearl of this study is if you add on immunotherapy to chemotherapy for all patients, in general, they will have treatment efficacy and benefit. But if you have to enhance your treatment efficacy and doing it in a more cost-effective manner, then we should select our patient at least with reference to the CPS higher than or equal to 5, which is shown in this forest plot. If you look at the tumor cell PD-L1 expression, that is the TPS, but nevertheless, those tumors with higher PD-L1 expression seems to have better and more favorable hazard ratio. Of course, we all know that the MSI patients will have a very dramatic response and control with immune checkpoint inhibitor, but that is something that we have all known before. Response and duration of response is also important. The response rate can be up to 60% with addition of immune checkpoint inhibitor compared to just 45% with chemotherapy. So the best overall response will be 12% complete response in the combination arm. The duration of response is very reasonable at around 10 months. Treatment-related adverse event is something that we all know. There's low new toxicity signals, and as well as the IRAE. So in summary, lifilumab is the first PD-1 inhibitor to demonstrate superior OS and PFS in combination with chemo versus chemo alone. And of course, the FDA has approved this indication in all patients, but personally, I think that to maximize the cost effectiveness, probably we have to take reference to the CPS of individual tumors. So, but what's the relevance for Asian? In fact, in the last AACR, this 6-4-line study has Professor Shen Lin has presented the Chinese subgroup analysis, which showed that a similar degree of benefit and even more enhanced hazard ratio. You think about the CPS in this category, and the hazard ratio will be the 0.68 in the overall population in the 6-4-line study. And they show that in Asian patients, probably the efficacy is more enhanced. But of course, that is hypothesis generating. We see the direction of the effect is not a confirmed one, but at least we will be more reassured in adding immune checkpoint inhibitor in our population. That's the same direction of benefit for progression-free survival in Chinese patients. And response and duration of response in Chinese patients seems to be more durable and even higher response rate with the combination arm. Treatment-related toxicity, one thing that because this is the annual scientific meeting of the Thai Association of the Study of the Liver, you are all very interested in the liver-related toxicity. Yes, and indeed, in Asian patients, we do seem to notice a higher rate of hepatic adverse event, probably due to underlying hepatitis B status and other environmental infection. So I have the pleasure to present on behalf of the Global Keynote 062 study on the Asian subgroup population. And it also echoed what Professor Shen Lin has presented for the 6-4-line study. In Chinese patient or in Asian patient, there's enhanced hazard ratio and benefit of adding immune checkpoint inhibitor to chemotherapy. So that is something relevant to our locality, relevant to our own population. The other things that we have repeatedly talked about is does PD-L1 score matter? Previously, I don't think so, because there are limited treatment options for patients. And in the 2nd and 3rd-line study, which showed that irrespective of the PD-L1 expression, immune checkpoint inhibitor do produce clinical benefit. But in the 1st-line setting, we have to place smart, we have to be cost effective, we have to balance the risks and benefit. So why not we look at the CPS score more carefully? And many will argue if we approve addition of lifilumab in all patients, then how about those with low expression or very low expression like CPS smaller than 5? probably these two subgroups may not have, although it's to the left of the utility, which means that there's some benefit, but on the survival outcomes alone, the effect may not be significant and may not be as huge as their counterpart with increased PD-L1 expression. But there's still reason of using immune checkpoint inhibitor in addition to chemotherapy in this patient with low CPS value, because irrespective of the CPS value, addition of immune checkpoint inhibitor seems to enhance the response rate of the treatment regimen. So that is one point, that despite low CPS score, we may still use immune checkpoint inhibitor, but that is subjected to individual counseling. IRAE and health-related quality of life, we all know that this is a successful treatment with the control of disease. The quality of life will be good, and that will also give you a quick reference for all the hepatologists or the physician here, knowing about the timing of onset of immune-related adverse event. The earliest will be about gastrointestinal, like diarrhea. The latest will be the pulmonary, like pneumonitis. Intermediate will be endocrine. So we have this in mind. But basically, with the low threshold of using steroid as an antidote, usually this IRAE can resolve with time and can manage effectively. And time to symptom deterioration in all randomized patients is superior with the addition of immune checkpoint inhibitor because of improved tumor control. So other lawful strategies, we are not just talking about immune checkpoint inhibitor with chemotherapy alone. We're also talking about immune checkpoint inhibitor with other combination. So basically, one of the things that I also do as a clinical oncologist is radiotherapy. So if you look at the Keynote 975 study, it's a combination of chemotherapy, immune checkpoint inhibitor, and radical radiotherapy that is ongoing. And there's combination of other target therapy with immune checkpoint inhibitor. One of them is the combination of HER2, anti-HER2 therapy and immune checkpoint inhibitor and chemotherapy. And this phase 2 study, which showed that there's promising result of combining trastuzumab, chemotherapy, and pembrolizumab in stage 4 HER2 metastatic gastric esophageal or GEJ junction, GEJ cancer. So this combination, although that is the early phase study, show a very promising progression-free survival as well as objective response rates of around 91%. Another thing with the nivolumab and other along the immune checkpoint inhibitor will be the combination of anti-PD-1 with anti-LAG-3. LAG-3 is basically another pathway of immune checkpoint. So by combining these two different immune checkpoint pathway, there is synergism of reversing T-cell exhaustion and enhancing immune eradication of tumor cells. So certainly, ladies and gentlemen, this is my summary. The treatment landscape of IO is rapidly evolving from single agent to combination, and to combination with lawfulty that we have just heard. An established role of IO with chemotherapy in different lines of treatment in both esophageal cancer and gastric cancer alike. Identifying the right patient and right therapeutic partner still are challenges. We have witnessed significant improvement in the treatment outcome of upper GI cancer with IO, but we are still not curing all those patients with metastatic disease. So there will be a huge challenge in identifying all these essential factors. But nevertheless, we can't be too greedy. At least we are seeing light at the end of the cancer journey tunnel. And that's the end of my presentation. I thank you very much for your attention. And please do not hesitate to throw me any questions in your mind. Thank you very much.
Have a question, even though I will start my question first of all. Professor Lam, can you hear me?
Yes, thanks for having me today, and good afternoon, everybody.
Yeah, good afternoon. I try my best to use equipment that may have some problems here because my assistant's gone somewhere. Anyway, I wonder about the squamous cell carcinoma and adenocarcinoma of the gastric cancer for the point of the biomarker point of view, that if in the practice we shall decide from the landmarks paper that you talk about, if the squamous cell, I have no question, like more than 10% of CPS score, or adenocarcinoma, you suggest at least it has an expression more than 5%. Can you obsessive on this point again? If in the clinical practice, we shall send it at the first time of the treatment by checking which is the cutoff point value that you think is better for squamous cell carcinoma in esophageal cancer, and which is better for the gastric adenocarcinoma?
Thank you very much. That is a very important question, because in our locality, mostly we are actually treating squamous cell carcinoma instead of adenocarcinoma of the esophagus. So I treat these two diseases or histology differently because they really behave differently, although they are included in the same study. But of course, for more benefit, we should choose patients with higher CPS score, for instance, CPS more than 10. But for squamous cell carcinoma, I will be more liberal if they have even lower CPS. But because they are esophageal squamous cell carcinoma, they're intrinsically more responsive to immune checkpoint inhibitor. I will still discuss the options of immune checkpoint inhibitor with the patient. And that's from the KEYLOGE study. And if you look at the CheckMate study, that cutoff even is not that really important. On the other hand, for adenocarcinoma, I will be focusing more on the CPS, because actually they do not have a standalone benefit from the addition of immune checkpoint inhibitor. So we have to be more stringent with the CPS in choosing immune checkpoint inhibitor for adenocarcinoma subtypes. So that's basically what I'm practicing in Hong Kong.
Okay, that is important because we found that interestingly, I just pay attention 2 or 3 years before, and we have the patient who has a signet ring cell, and almost I have failed to use other kind of drug, but the patient has a high CPS score, and so I decided to use with her and him. That's 2 patients still keep alive until now, even after recurrence metastasis, and they cannot use the chemotherapy. So for my feeling of the utility of the PD-L1 checkpoint, I think it's most importantly to see at the CPS score in adenocarcinoma. And although it's not common, but half of them has a positive and high score. It's surprising me too. So about 50, 40, sometimes I look for the frequent point of the CPS score in our
Yeah.
patient later on. That is very nice of your study that get me some idea about this. And the
Yeah.
second question, may I ask about the trials on ongoing study for the neoadjuvant. Thank you for your very interesting kind and talk to our interesting point of view for the treatment of the esophageal and gastric cancer, especially for the point of immuno-oncological treatment. And I would like to thank you for your kind answer for my question and for the audience question. For the summary today, I think I used the same slide that I showed you on the first slide that when I first talked in the session. So nowadays, for the surgery and neoadjuvant chemotherapy, there is no consensus at all. But after neoadjuvant chemotherapy and surgery, we still have problem with the future treatment for the patient who has a poor risk of the recurrence and metastasis. So nowadays, targeted therapy is one of the choice or best choice for the further treatment in this group of population, even for the second line or third line after the definite treatment. And there is many options that most relevant to the host response to the therapeutic agent. I still have some questions that Professor Lam may reply us about the enhancing of the therapeutic effect by the immuno-oncology drugs to the chemotherapy. So the current use chemotherapy for the treatment is the backbone. However, the problem is still involve the chemo resistance and poor prognosis in advanced stage, especially stage 4. And the problem related multidisciplinary treatment issue for the advanced drug selection, even for the global or Asian country, some kind of regimen chemotherapy plus radiotherapy, and you may add immuno-oncological treatment. About the biomarker expression or combined positive score that we can use to select the program date ligand 1 efficiently help to select higher response group of the patients. Treatment-related adverse effect events may be safe, as Professor Lam referred to the data. The residual tumor after neoadjuvant chemotherapy in prolonged overall survival for the esophageal cancer, GEJ junction, or gastric cancer that is ongoing trial may give us the result year later. Chemotherapy resistance may cause poorer outcome for the overall survival in terms of partial responders with the residual tumor after neoadjuvant chemotherapy and complete resection. Positive lymphatic metastasis cause poorer survival in more than the half of the complete resection patients that we found the recurrence with metastasis cause poor prognosis. I think the immuno-oncological treatment surely that promising to enhance the chemotherapy effect in nearby future, and we wait for the fruitful data of Professor Lam later. Thank you very much for your kind attention for this very innovative and very fruitful session. And thank you for our delegate speaker, Professor Lam. May I close this session? Thank you.